Thank you very much for joining us. My name is Sandy Shefkin. I am the Pediatric Program Manager at the American Occupational Therapy Association, and my co-facilitator is Scott Bloom, who is the Director of Mental Health Services in New York City's Department of Education. Today, we will be providing you a one-hour free webinar entitled Bridging Understanding about Trauma-Informed Care. Mariola, okay, I'm sorry, to get the slides to go. There we go. Thank you. We want to thank the IDA Partnership for hosting the webinar and for their ongoing leadership. The websites for the IDA Partnership are www.ideapartnership.org and www.sharedwork.org. And Scott and I encourage you to go to the IDA Partnership website and download the many free tools that they offer, including a blueprint for authentic engagement. All the tools from the IDA Partnership were developed by the field, and they help to build community. The IDA Partnership is funded by the Office of Special Education Programs, OSEP, and they developed collaborative learning communities. They help to bring people together as teams to do work together. The IDA Partnership includes over 50 national organizations, technical assistance centers, state agencies, family partners, and more. Their goal is to improve the lives of youth with disabilities in schools and through school towards college, career, and community integration. They sponsor many communities, and one of which is a national community on school behavioral health. Whoops, we got ahead of ourselves here. One of the practice groups of the IDA Partnership within the National Community of School Behavioral Health is learning the language. I'm not sure how the slides are getting forwarded without me doing it. Go back here. One of the practice groups is Learning the Language. Learning the Language is an interdisciplinary group that meets regularly to help bridge understanding between mental health and educational systems. The learning objectives are listed here for you. And during the presentation, you're going to hear from 3 presenters who will discuss trauma-informed care principles and programs, and they will relate this content to the ongoing need of learning the language, which is to build strong communication and collaboration, again, between mental health and education systems. At the end of the presentation, there will be some times for questions and answers, and we encourage you along the way to post your questions or comments in the chat room. Mariola, we're hoping that now, before we get started, we could take a look at this poll that's now up on the posted for you and ask you to vote. We'd like to know who is on the line today. We want to get a sense of our audience participants, and hopefully they reflect a full complement of providers to show that we truly are community-based. So could you spend just 1 second, we'll keep it open for 1 more second here, to poll who is on the line. Okay, we're going to close the poll, end the poll, and you can see here that we do have a number, I guess our highest percentage, 32%, is mental health providers. We also have related service providers on the line. We have educators. We've got technical assistants. We have some representation from child welfare, from juvenile justice, and then we have the broad category other. Hopefully we have some parents and some other representatives that are not listed in this polling group. And in fact, if you'd like, you could type into the chat room what other representation you have in this call today. And it really speaks to our community approach to have a full complement of providers and who we're missing on the line today, and possibly sharing this information with others after the recording is done, and hopefully this will be available to you in a recorded form. We're going to go back to our slide presentation and ask you, as you hear our presenters, to reflect on some information. What information will you hear today that will guide your practices? What are the common themes threaded throughout this presentation? And how can we all work in terms of learning the language, learning each other's language, to better communicate and strengthen for better understanding and for better outcomes for our children and our families. So without further ado, I'd like to turn this presentation over to my co-facilitator, Scott Bloom, who will introduce our speakers and then lead a Q&A at the end of this presentation. Thanks, Scott.
Thank you, Sandy. Our first presenter is Dr. Adam Brown. Adam is a licensed psychologist in the state of New York. He's a clinical assistant professor of child and adolescent psychiatry at the NYU Langone Medical Center and associate director of the NYU Center on Coordinated Trauma Services and Child Welfare and Mental Health at the Child Study Center. Dr. Brown is the lead trainer and consultant on trauma systems therapy, otherwise known as TST, and works with organizations nationally and internationally. Adam?
Thank you, Scott. I'm hoping everyone can hear me. So what I want to do is to introduce people very briefly to our model, Trauma Systems Therapy. The manual, as you see on the screen, is Collaborative Treatment of Traumatized Children and Teens. There is a new version of it coming out hopefully this summer, the second edition. And TST was developed in the late 90s, early 2000s. The book was published in 2006, and it's really an attempt to address what we have come to understand as the impact of traumatic events on child and adolescent development. We know that there is a significant impact on the neurobiological functioning, brain development of these kids, which impacts their ability to have relationships, to do well in school, with lots of significant impact across the lifespan. I'm not going to go into the details of how you do TST, but rather I'm going to focus on how TST works in terms of systems and organizations, in keeping with the theme of learning the language and helping providers to speak the same language. So TST, as opposed to some other models for addressing child traumatic stress, is not only a clinical model, although it does address the difficulty that traumatized children have regulating their emotions and their behaviors. So it does do that, but in addition, it's also an organizational model, so that we don't train individual clinicians or providers when we do TST, we train organizations, so that we identify an organization that provides service to kids who are traumatized and at risk, and we train the entire organization to become a trauma-informed organization using the TST model. We don't think about kids with symptoms as the recipients of TST. We think about what we call a trauma system. And the way we define that is a traumatized child who experiences what we call survival in the moment states. That means when a child who has a trauma history is presented with a reminder of that trauma. Let's say a child who was physically abused and lived in a domestic violence situation is now in a situation where adults are using loud voices and punitive discipline practices. That may be a reminder of previous trauma. That child enters survival in the moment states, which are ways of responding that are similar to the way they responded in the original trauma, right? Fear, aggression, whatever that might be. Those same responses are now elicited when reminders of trauma are present. And the other side of the trauma system is a social environment or system of care that's not able to help that child to regulate or to manage those triggers and reminders. So we're always looking at the child's responses and the environment's ability to help that child be protected from reminders And our interventions then address the system of care or the social environment by looking to stabilize those environments so that they're not triggering for kids anymore, and so that kids are getting the support and the help that they need, while we're also looking to build emotion and behavioral regulation skills to help those kids to better cope. TST accomplishes that by integrating 4 key service elements. All kids in TST get skill-based psychotherapy to help them to learn to better regulate. All kids get home and community-based services, because if we're looking to identify the sources of stress in the environment for kids, we need to be able to go into environments. So if we were to have a strictly office-based model, we wouldn't be able to effectively assess and provide intervention at the level of the environment. So we need to be able to go into homes, into schools, to be able to provide that level of care. Psychiatry, psychopharmacology, that doesn't mean every traumatized child needs medication, but we work hard to have psychiatrists be a core member of the TST team so that all kids can have that evaluation and that perspective available to them. And legal advocacy, which means that these kinds of situations are often highly complex and require more than what a clinician or a psychiatrist or a caseworker has been trained to do, so that we have legal advocates who are giving pro bono time in most cases to be consultants to the team to help us to sort through the myriad of complications that are involved in these cases. TST is a team-based approach. So we need to be able to form a multidisciplinary team that includes the child, the caregiver, the teacher, the clinician, the caseworker, direct care staff in programs that involve that, after-school staff, extended families. We need to be able to engage all of these people as core members of the TST team that are working together to develop what we call TST priority problems and TST treatment plans, so that these folks are all speaking the same language. When we begin a TST implementation, we're looking at what the agency is able to provide by itself and what partnerships are necessary in order to get all those core service elements represented. So when we start with an agency, we start by doing what we call organizational planning. And it starts with identifying a TST leadership team within the organization and meeting with that team weekly to think through all the factors that need to be in place for successful implementation. So before we would train an agency, we help the agency think about, can we represent those 4 service elements? Do they all exist within the organization? And if not, what kind of partnerships need to be in place? If we do provide all of those services, are they all within the part of the organization that will be doing TST? And how do we form the partnerships, either internally or externally, that are needed? If we're not able to provide them internally, what kinds of organizations do we tend to work with on a regular basis? What are our referral relationships? And can we pull those folks in to be a key part of the team? Success stands or falls on whether we can develop a strong working alliance with all the elements of our own agency and with our community partners. The working alliance is defined as the agreement between the organizations to work on a specific set of problems in specific ways towards a set of specific solutions. So in other words, we don't want to refer kids out to get psychiatry if we don't provide it in-house. We don't want to refer kids out to get psychotherapy or legal advocacy or case management. We want to invite those providers in to be members of the TST team and to work with us in an integrated way, so that there's one TST treatment plan that all those providers use. And we're working on one TST priority problem, and we're agreeing on the solutions that will be accomplished if we work together in an integrated way. So important questions to ask: how much do we know about our partner organization and the way they experience what their priorities are and what gets in the way of achieving their priorities? How much does TST align with those priorities? Meaning, will those organizations see TST as helping them to accomplish goals that are important to them? And if it's not in place, how do we build that connection so that partner agencies will understand how getting involved as providers in this TST team will be meaningful to them? So TST is designed to help create strong collaborations through the process of organizational engagement and planning. So we have a process that we call Ready, Set, Go. In engaging with youth and families, we think of Ready, Set, Go as the process of developing a shared understanding of what are the problems and how we're going to work together to solve those problems. The parallel when we're building organizational partnerships is organizational Ready, Set, Go. In order to effectively engage a partner organization, we have to understand what their biggest priorities are and what their sources of pain are. And then we need to see if we can use TST to build a plan to help address those sources of pain. We have collaborators that are important within an organization. There's the champion, who's the person in the organization who wants to bring in TST, but there's also the gatekeeper, the administrator who makes decisions. And we need to engage both of those. We want to think about who in the organization needs to support the plan to make it work, who outside the organization needs to support the plan, and what the staff need in order to be supported to make this work. We need to think about how interested staff are in doing the model. Have they contributed to the building of the organizational plan? What might they be thinking when we say we're trying to bring a new program in? What has their experience been with that in the past? Have we ever tried to bring a new program in before, and what happened? Let's learn from our experience and from history. Will people think, oh, this is just the flavor of the month and we don't need to pay much attention? Or do we get people's attention by making clear that this is a commitment the agency is making to moving in a direction to solve some of the problems that have been identified? Then we need to have a plan to engage and train staff and to think about how to support staff through that process, because we know that organizational change doesn't come easily. We need to build an alliance with key stakeholders, both internally and with partner agencies. We need to think about how to educate and provide sufficient information to key stakeholders about trauma, about TST, and about how we're going to use TST to address the organization's priorities. And then we need to anticipate what the problem areas might be so that we can troubleshoot barriers before we even encounter them. And then, as in with good clinical care, that alliance needs to be checked and rechecked over time. We need to set up an evaluation plan that allows us to track whether we're making progress towards our goals. So when we set up an organizational plan, we need to think about, okay, an organization has identified their key priorities. We need to think about what are the metrics that help us know whether we're reaching those priorities, and let's have an evaluation plan to track progress and to be able to check that progress over time, and to adjust the plan periodically if we're not getting the kind of outcomes that we want. We want to let you know that TST is a model that is based on core fidelity, but we think of our basic TST fidelity as a platform on which to innovate, because we know that the way you do foster care or education or outpatient treatment in New York is different than the way you might do it in Kansas or in Texas. And the needs of certain populations are going to be different than others. So we encourage sites who work with us to come up with adaptations to the model. So through what we call our TST innovation community, we now have adaptations of the model for outpatient treatment, for residential care, for foster care, for school-based mental health, for refugee populations, for substance abuse populations. We're now doing TST in 14 states around the country and the country of Singapore. And we're continuing to come up with adaptations all the time. I want to close my portion by just giving you one example. in the city of Washington, D.C. right now, we've been working with their child welfare arm of the government, which is the Child and Family Services Agency, CFSA. And CFSA has now been doing TST with the agencies that provide foster care to kids in the District of Columbia. As a result of that, we have invited all the other stakeholders to be a part of the training and to understand the work that we do. And the public mental health administration there, the Department for Behavioral Health, has said, we need to get in on this, right? We're the ones who are providing mental health services to kids in foster care. We want to be on the same page. So we are now undergoing a major citywide project to provide training to the public mental health providers in the city, so that not only will every child in foster care get training, or the agencies that provide foster care to every child get training to provide TST, but now all the mental health providers are getting that training as well. So children who are in both systems, foster care and mental health in the city, are all going to be trained to get TST, so that we will have teams now that truly are multi-agency, multidisciplinary teams, all been trained together. And as a result of this work, the folks that provide juvenile justice services to kids in the city are now interested as well. And we are in the process of contracting with the Division of Youth Rehabilitation Services, which is the juvenile justice arm, so that the three major system providers in the District of Columbia are all going to be trained to provide TST. And what that means is that as kids move through different levels of the system, all those different members of the teams are going to speak the same language. A kid who has a TST treatment plan and priority problem developed in one aspect of the system, that will follow them to the next level of care, and those next set of providers will understand that language and be able to pick up where the previous team left off. This is a very exciting development for us, and one that we think can become a model for other systems. The obvious missing piece here is the education system, which will be the next nut for us to try and crack. So that is the brief overview of TST and how we're using it to sort of create common language and systems. I'm going to turn this over now to my colleague, Lisa Barron, to talk about how this is happening in the public schools in Boston.
Okay, thank you,
Hi,
Adam.
everyone.
I want to I was just going to introduce you, Lisa.
Okay,
Lisa
sounds
Barron
good.
is a licensed psychologist in Massachusetts and a certified health services provider with the Alliance for Inclusion and Prevention in Boston. She is the director of Connecting with Care, a school community partnership to place mental health clinicians full-time in the Boston public schools. Lisa is a member of the Trauma Systems Therapy National Leadership Team and has implemented the nation's first school-based adaptation of TST. So we're all eager to hear how that's going, Lisa.
Well, thank you very much, and thank you for having me, Scott and Sandy and the IDA partnership, as well as Adam Brown and the TST leadership team. It's a real honor for me to talk about our program here in Boston. And we've been here for about 8 years now. The picture that you see on your screen is the hub of our product, Connecting with Care, and it's located in one of the poorest, lowest socioeconomic status and high violent crime areas of Boston. And it also happens to be where my office is and where I'm speaking to you from today. So just to give you a bit of an overview of Connecting with Care, it's a bit unconventional model in the sense that we don't actually provide the services directly, but we broker them between the schools and the mental health agency partner that we have. And what that means is that we have to learn the language, really, of all of our partners, the schools and the mental health agencies, and develop, like what Adam was saying, an understanding of the organizational mission or priorities and the sources of pain of both the schools and the agencies so that we can make this work.
So we developed this program in collaboration with key community stakeholders, originally to address racial and ethnic disparities in children's mental health access and treatment. And we started with just the Frederick School in Dorchester, the picture that you previously saw. And we've been now in a total of 15 schools with plans to expand to 6 to 10 more schools next year in the Boston Public Schools. So we're really growing, and that's exciting. And this is just a list of our current and founding program partners, funders, and schools. And we have three major goals with Connecting with Care. We are not just a TST treatment program, but we treat the full range of mental health disorders in children, common to children. So I'm going to talk to you a little bit about how we sort of work at a meta-organizational level to bridge the communication and the language between schools and mental health agencies. And then I'm going to talk to you a little bit about how the TST piece works specifically. So the first goal for us was better access to children's mental health services. I mean, there's a whole host of reasons why people in these communities don't access children's services in the clinics. You know, there can be issues of employment, they work multiple jobs, there could be transportation barriers or child care barriers, et cetera. But kids are in school most of the time. This is where they live, where most of the important people in their lives are found. And so it really makes sense to provide services in schools. The second goal is to provide these services in schools on a full-time basis. And the full-time model is really important. It's also important for how we work with TST. But if we talk about priorities for schools, they definitely love the full-time model, because how this typically works is you have agencies coming into schools on a part-time, maybe 2 days a week basis, going in, seeing kids, leaving. And while this is good, while we get some services to kids, it's really a kind of a broken model where there isn't a lot of communication and a lot of common language between the two parties. So the full-time piece is really important to deeply integrate the clinician into the culture of the school. It's also a great model because it eliminates the stigma of mental health. It's seen in the school as just another service provided, just like speech or OT would be. So, and then the third piece is improving the quality of service delivery in schools. This whole partnership brokering piece, very important, because it's the single reason why more agencies don't do mental health in schools, because they don't really understand the needs of schools. Schools don't understand their needs. I'll give you an example. For example, school agencies need to understand that mental health treatment is always in service of academic achievement. The primary goal of schools is teaching and learning, right? So mental health treatment really, while we need to address the diagnostic disorders in kids, we also need to pay close attention to how this child is functioning in school for all. The other piece is that agencies may need to adjust their policies and their infrastructure. For example, our partner agencies provide our clinicians with laptops so that they can do their billing and their notes in the environment of the school and not have to leave and go back to the agency after school. So, and then also the whole process of intakes, that's going to take place in the school environment as well. So some agencies have had to readjust how they set up their process. Now schools, on their part, don't understand what's going on with the agencies. They need to understand that the clinician needs to be full, because the clinicians are billing insurance to help support their positions. So they need a full caseload to sustain them, and also to sustain them to cover weeks when school is not in session, like, you know, the vacation weeks and certainly during the summer. So they need to be productive. So that is a piece that needs to be watched very carefully. The other thing that they get confused about is because they have full-time clinicians in the schools, there's a bit of role confusion. These clinicians are not district employees, so there is a limitation on what they can do. And I regularly get contacted to sort of reinforce what the role is of these clinicians. So the coordination piece is very important. That's a huge source of pain for the agencies. We need to make the finances work for them. So on a weekly basis, I track the productivity of the clinicians. and I have to establish a point person at the schools for the school referrals. I have regular meetings with them. I have regular meetings with the clinician and their agency. And I have to make sure that the clinician ultimately is being productive and is seeing the students that the school finds is a priority to be seen. So I'm constantly speaking the language of both entities. The third bullet point is data collection. Data, we all know, is really important. We need the finance data to feed back the agencies so that they can see how they're doing. And it's also really important for the purpose of engaging future partners into taking this risk, because mental health agencies operate on very slim margins. And we collect TST data and clinical outcomes data too, because that's very important. Funders want to know this kind of stuff. And this year we're piloting an assessment tool that the Boston Public Schools are using, because we want to be able to feed back progress to the schools that directly reflects academic achievement and performance in the school. And ultimately, we are the TST's first school-based adaptation. Okay, so why did we pick TST in the first place? Well, Adam gave you a pretty good example of how TST is a systemic model, and that is important. We started this program talking to the community and saying, we're going to have full-time clinicians in the schools, and they just love that idea. And we said, well, if we were to have a specialty for these clinicians, what would you want it to be? And they said, oh, you guys, we have so much violence and trauma in this neighborhood. We really need, that would really be great if you guys could have an expertise in trauma. So we set out looking for a trauma model. And we needed a model that was going to work really well in the schools. What was going to address the teacher's source of pain? You know, all the disruptions to teaching and learning, not just the disruptive behaviors that upset the whole class, but also the kids that just can't pay attention because they're experiencing traumatic memory or otherwise are not paying attention. So we also, with our full-time model, we wanted something that would help us work on a daily basis, if necessary, with teachers and staff so that they could understand the behaviors that they were seeing and respond in more helpful ways, so that they could understand that these were not just oppositional behaviors, that these kids were reacting in traumatized ways. We also thought that this would be a great model because actually one of the open trials occurred right here in Boston 10 years ago, and so we knew it would work with our population. And lastly, we have a system of care in Massachusetts called the Children's Behavioral Health Initiative. And this means that families who have Medicaid insurance are entitled to a full range of mental health interventions, both outpatient, in-home, community interventions. So we needed something that would work well systemically, and that is TST. So what I'm going to do now is just give you a brief illustration of how TST looks in the school, with the family, and with the community. And this is an actual student in one of our middle schools. His name is Henry, and he's experienced multiple moves and chronic homelessness. He lives with an abusive alcoholic father. He just had a recent disruption to his living area, moving from New Mexico to Massachusetts, where his mom lives, but he doesn't really see her very often. And then as a younger child, Henry was often awakened by his drunk father and beaten up for no reason. So now, Henry often, we found out, has to retrieve his father, who is the primary caregiver, from the bars late at night. As a result, when Henry gets triggered, he can black out and behave very violently when he perceives he's being treated unfairly. And lastly, Henry's only 12, so he's got a lot on his plate for a young guy. So where do we start? So the first place is to give the teachers the language of TST. So what I do with schools is to train the teachers and the staff, and I call it TST-informed interventions. I give them the basics of stabilizing the environment while stabilizing the child's dysregulated symptoms, but not too heavy mental health because that's not their area of expertise. But it does give us a common language so that when the clinicians are working with them, they can understand where the clinician is coming from. And so we'll start out with the clinician observing Henry's behavior. He may go to Henry's classroom, he'll go to the lunchroom, he may go to the gym, etc., and just see how Henry is interacting with his environment. And then he'll also get the teacher's perspective on what gets Henry upset. and when it's happening and where. We call that a moment-by-moment process. So in consultation with Henry's teachers and also the observations that the clinician has, we're going to work through the TST analytical process and ultimately come up with a couple different types of themes. One is the environmental threat. What is actually going on in the environment that triggers Henry? And we came up with this theme of perceived injustice for Henry. And then we also wanted to come up with another theme with how Henry responds to these perceived injustices. And when that happens and he gets triggered, he starts yelling and throwing things and being dangerous and leaving the classroom. So again, the point is here to help the teachers understand that Henry is reacting to perceived injustices based on his traumatic experiences. So this really helps the teacher to not personalize what's happening. They can understand that this is whatever is happening in the classroom is a trigger for what is upsetting Henry and his original traumas. And we may not be able to control Henry's behavior immediately, but we can control our own behavior. So we want to help the teachers to choose alternative responses. And these are some of the tactics that we tried, including having lunch together one day a week so that Henry could have a different experience of this teacher and so that he could trust and build rapport. So that's what we do in the school environment. It's an example. So what else do we do? There's a lot going on in Henry's home, as we know. So we have gotten an in-home therapy support to address some of the family's sources of pain, and that's going to be, for example, trying to find housing closer to Boston. Henry was driving 2 hours. He was getting a ride 2 hours to school every day and 2 hours home, which was just unbearable. We needed Dad to help find some support for his alcohol addiction, and we also needed some parenting skills for Dad to help improve the parent-child relationship. So that was really important for the in-home team to be doing. The housing piece was huge. And then the other piece that we teach our clinicians that is so important and crucial is to maintain this treatment alliance with the providers. There has to be regular communication. When we're first running the treatment plan, we want everyone to be on board with that. And then we want to have a regular review and make sure everyone's still doing that. So whenever possible, we like them to come to our TST team meetings so we can just check and make sure we're all still on the same page and address any barriers that we may be coming up with treatment. Also, it's really great for the clinician to be able to inform the providers of important school meetings because we hear from schools all the time that they never hear from providers. So when our clinicians are able to link the providers to the school, that's another really important piece. And ultimately, we also work with the student. So we want to teach, slide is a little bit off, but we want to teach Henry how to understand and begin to regulate his emotions. We're going to help him build some coping skills. And then we're also, once the environment is stable enough, we're going to challenge Henry's distorted thoughts so that he can improve his relationships with teachers and peers. And ultimately, we want to help secure Henry's own buy-in to the school. So we want to work with teachers around finding some opportunities for him to experience success. So maybe helping teachers with tasks or maybe doing some therapeutic after school just to give him a better experience of school. Some challenges for TST implementation in the schools is ultimately staff turnover is a major challenge for us. Whenever you have leadership at the top, whether it's the school or the agency, there can always be different priorities for the next person. So sometimes we lose a partner here or there, but we have to keep moving on and working with new partners. And then so what we do is we have to also hire clinicians to follow the school schedule. That means not hiring them in November because the schools, they want to get started in September here in Boston anyway. And it's very disruptive to the school if somebody new is coming in the middle of the school year. Another challenge is that the agency employers are reluctant to give up potentially billable time for clinical meetings like TST. And then the last challenge is family engagement. So how we made some adaptations to the model to address these challenges. So again, I mentioned earlier that I provide TST-informed training for teachers and staff. I also do that for agencies so they can learn the language of TST as well. And yes, we hire the clinicians during the summer for September start. And we moved our clinical team meetings to after-school time so that we don't interfere either with the school day or with the billing process. The real challenge that we have is family engagement, because unlike the clinic-based work where families have to bring kids in to be seen, the schools are generally making these referrals. And that may mean when a school calls a family to first tell them that counseling has been recommended, the family is saying, well, gee, I don't see that problem here. If you guys have a problem with Johnny, why don't you fix it? So we have to talk to our clinicians about, from the first phone call, how to approach parents to get their perspective on what's going on and obtain their source of pain. We use the principles of ready, set, go actually from the start of all treatment, because we don't often know that a referral is going to be a trauma case until we're a few weeks in. Okay, and by the way, about 25% of all of our clinicians' caseloads are traumas. And so we started to pay a little bit more attention on how to engage the families. And we came up with scripts to use with families. The clinicians have shared strategies. And in 2 years, our family engagement numbers increased by 80%, from 10% in 2009 to 10 to 18% in 2011 to 12.
Lisa, I'm sorry to interrupt.
Yes.
Lisa, sorry to interrupt you, but
Yes.
I'm going to have to ask you to wrap up a little bit here so we can give time for our
Yes.
next presenter.
Absolutely. Yes, and I'm almost finished. Thank you.
Okay.
So our TST outcomes, we have improvement by about a third in all of our areas. In this case, not the service system, but we've gotten a lot better at that lately, and these results were certified by Dr. Sachs and his team. And ultimately, CWC is a school-based mental health model that deeply integrates school and mental health using TST. And our data demonstrates that TST is an effective model for the treatment of trauma in schools. And that's it, just some resources. We were funded for 5 years by Robert Wood Johnson Foundation. Thank you very much.
Okay, Lisa Barron, thank you very much. There are some questions that people are putting up on the chat, and if you scroll down, you'll see some of the answers that our presenters are answering, so that we'll have time to hopefully take a few more at the end. If not, just a reminder that this will be posted on sharedwork.org, and we will create a wiki page so people can ask further questions, and we'll make sure our presenters get to them. So without further ado, let me introduce our last presenter, Erika Tullberg. She's the principal investigator for the NYU Child Study Center's Atlas Project, an administrator for Children, Youth, and Families funded project, which aims to make changes to New York State's child welfare system that improve the social and emotional well-being of children by applying a trauma lens across systems. She's also the co-chair of the National Child Traumatic Stress Child Network Welfare Committee. And I want to introduce now Erika Tullberg. Erika?
Hi, Scott. Thanks so much. Can you hear me?
Yes, we can.
Okay, great. I cannot advance the slides.
How's
there
that? You just tell me when, and I will do it for you. Just say next.
Okay. There's some animation in there, so this may get a little tricky. If there's any way to get it back over to our computer, that would be fantastic, but we'll figure it out. Oh, there. I just figured it out. Okay.
Okay,
so, good. Terrific. So, hi, everyone. Thanks so much for joining us. I'm going to kind of shift gears a little bit and talk about one of the main challenges when you're implementing any sort of a trauma model, or even not a trauma model, but just working with children and families that have been impacted by trauma, which is how it ends up impacting all the staff members working with them, which I think is normally or often treated as kind of an ancillary issue, but I think we see as really central, because otherwise you're not really going to be in the position to do the good work. So just going back to the earlier discussion that Adam had about the trauma system, I think one of the things that's so important about this and so relevant for what I'm going to be talking about today is that, again, on the left side here, you have the traumatized child, and on the right side, you have a social environment and system of care. And I think what we forget is that we are part of that social environment and system of care. It's not just family members, it's not just people in the community, it's not just other providers, but that we ourselves, our agencies, are part of that environment, and we can either help to mitigate trauma responses and trauma reminders and additional traumatic experiences, or sometimes either, oftentimes inadvertently can exacerbate those. So when we're talking about looking at trauma, we really have to pay attention to how, kind of what role we play in that as professionals and as members of the broader service system. So just to take a little bit of a step back, so people talk about the term secondary traumatic stress. You may have also heard the term vicarious trauma or compassion fatigue. We could give a whole webinar on just those terms and all of the nuanced differences between them. There's a lot of interesting debate within the field about that. But for the purposes of this presentation, I'm going to use the term secondary traumatic stress fairly broadly and really just talk about how it is related to people who hear about firsthand experiences of other people's trauma. And actually in a minute I'm going to extend it a little bit beyond that. But the idea is that people just through the process of hearing about other people's traumatic experiences, you yourself can actually start having your own trauma symptoms that very much mimic PTSD. So this slide shows the different kind of main domains of PTSD, and people who have experienced secondary traumatic stress can start to have these symptoms for themselves. They might have nightmares about their clients. They might become avoidant of certain kinds of clients, that sort of thing. That being said, one of the issues that's challenging when you're working in the field of child trauma is that PTSD is a fairly narrow diagnosis, and a lot of the kids that we work with don't necessarily meet all the criteria for PTSD, so they often come in with a whole host of other diagnoses like ADHD or conduct disorder or bipolar or lots of NOS things or rule-outs. On the kind of caretaker side, I think it's also important to note that not everyone may meet the threshold for having kind of something that would be diagnosed as secondary traumatic stress, but we can nevertheless have a lot of symptoms that are really linked to our experiences of working with kids and families and colleagues who are dealing with these sort of things. So in a workplace situation, you may see people who fit that kind of clinical criteria, but you may see a lot of this stuff as well. And I'm not, for the sake of time, going to go through these one by one in detail, but just to say that this is a lot of the dynamics that you might see, again, in yourself or in your colleagues, particularly reactivity, particularly, well, I would say actually particularly all of them. Now, what's interesting is, I think in workplace settings, my background is in child welfare, but I assume the same is true in pretty much all child serving systems, that one could look at these sorts of things and say, these are performance issues. These are indications of kind of a bad employee. But if you use that trauma lens, you can really see this is part of just, again, the natural impact of the work. Now, why is this such a problem in our system, and why are these things so pervasive? Again, I'm not going to go through this in detail, but just to say that I think this graphic shows that, at the core of it is interactions with traumatized children and families. And again, that's that first, kind of firsthand exposure to those trauma stories that was referenced on that definition slide a few slides back. But what happens when you're working in organizations that are working with these kinds of children and families, and you're working with staff who have developed some of the very symptoms that were on the prior two slides, then you're also impacted with the relationships that you have with those folks. You're impacted by the way that it impacts the organizational culture, and I'll talk more about that in a minute. You're impacted by the fact that the other systems that you interact with, whether it's, it sounds like folks on the calls are on two sides. Some of you are mental health folks who work with schools. Some of you are school folks who work with mental health. So a lot of time you probably see each other as part of the problem because the systems that you're working with are having a lot of the same characteristics that were on the earlier slide. People, other systems, child welfare, hospitals, juvenile justice, et cetera. And then I think really importantly to acknowledge is, this kind of biggest circle here is the external context in which we're all working, which to be quite frank is generally pretty negative, generally pretty beating up on our systems. No one is really writing stories in the newspaper about how wonderful foster care is or how wonderful our schools are doing at educating kids. Pretty much the public focus and perception is often negative, and that certainly kind of feeds into all of this and causes an additional level of stress, particularly from kind of the political leadership that ultimately most of us are answerable to. So when you're looking at this on an organizational level, and again, this could be a whole webinar or a whole semester's class in and of itself, so I'm not going to go into this in detail. But just to say that just like with kids, as Adam spoke about earlier, just as you have to deal with kind of the kids' own personal experiences and reactions and the environment that we're working with, when you're dealing with traumatic stress that staff are having, it's important to look both at the needs of people who are directly impacted by trauma, whether that's as part of their work, so in a secondary way, or perhaps also as part of just their life, because they're people who have the same kinds of challenging experiences that many of us have had just in the course of our lives. Often there can be a lot of reverberation, between what you've experienced personally and then what you see at work, and they can kind of, the traumatic stress associated with them can kind of feed into each other. And then the other half of this kind of coin, so to speak, is the impact that trauma has on the organizational culture and functioning. So for the remaining 3 minutes that I have left, I'm just going to talk about that piece of it for a minute, literally. So there's some questions about strategies. Again, I'm not going to go into any of this in a lot of detail, but just to say that as you're thinking about these issues, these are some of the questions that I would encourage you to be asking about yourself and about your organizations. And I'm going to go through some kind of broad, more suggestions and conceptualizations to kind of leave maybe more food for thought for folks. Because we don't have time to go into them in detail, but just to say that it's a way to kind of start thinking about these issues in a way that's a little different than the typical response, which is to kind of have a wellness day and have everyone do yoga for an hour and then say okay, we checked off that box, right? That's often how organizations deal with these issues, and I would say that's really nice and certainly isn't hurting anybody, but it's certainly not sufficient in terms of really shifting organizational culture and kind of embedding that trauma-informed lens into this part of the work. So one issue would be to look at these sorts of things that I listed earlier, and you may have your own list of what you see in your workplace, and really to say okay, so what do we see, and how would we operationalize it, and how would we track it, and how would we know if it's actually making a difference? So if you think that negativity is the biggest issue, that everyone is just beating up on each other, really trash-talking clients, supervision is kind of not working because people just feel attacked all the time, then maybe that's the focus, and saying, okay, how can we really incorporate, not to eliminate looking at problems, because obviously we always have to look at what we can be doing better, but how can we intentionally focus on what is also going well. So that's just kind of one quick example of how you might operationalize some of these issues. There's also some materials out there online and that are available. This is the Resilience Alliance. This slide is a module from a curriculum that I was part of developing. It was a child welfare focused curriculum, but I think it's very adaptable to other service settings where we're talking about resilience skills. This particular skill is about reactivity and kind of self-monitoring, and gave people more of an understanding of kind of how to connect to their own reactivity that they may not even be aware of, and creating kind of language for people to talk about how themselves were feeling and how they thought their colleagues and staff were feeling in a way that didn't feel accusatory or stigmatizing. So there's a whole lot of examples. If you Google Resilience Alliance NCTSN, or it'll actually on the last page I have a resource list, and the NCTSN information is listed there. So I talked a minute ago about, I'd like to kind of trash talk self-care, not because I don't think self-care is important, but just because I feel like that is what always people turn to kind of exclusively. And so I like to kind of flip that a little bit and say, okay, instead of like giving everyone a yoga class, let's think about what would organizational self-care be? How can you operationalize some of this on a broader level? So instead of, giving people a seminar about how it's important to, have boundaries between work and home, and then emailing people at 8 o'clock at night and expecting them to answer you, because that's not really helpful. Those are mixed messages. Could you agree as a staff? Could you agree as an office? Could you agree as an agency that, as an example, unless it's a true emergency, no emailing after 6 p.m. or 7 p.m. or whatever it is? Are there things that, again, everybody in the organization can do? Because these are issues that don't just impact frontline staff. They really go up the line and impact people in different roles in different ways. But when you're talking about organizational culture, you really have to look at how is everyone working together to address these issues. Parallel process, this is just really kind of taking some of what both Adam and Lisa were talking about and saying, how can we apply this to us? Some of what we're doing with our kids and families, how is it relevant to the dynamics that are going on within the office? Again, earlier I talked about the negatives, so I won't revisit that. And then kind of looking at language. So I think a lot of the time, leadership in particular is hesitant to address secondary trauma and this organizational culture piece head on, is because it ends up feeling like a personal attack on the leadership, because it just becomes kind of a trash talking and venting session, and that's not really productive. So is there a way to talk about these issues in a way that is productive, that does feel helpful, that is kind of solutions focused, and that doesn't kind of feed into that factionalism that was mentioned earlier, but is something that kind of becomes part of what the whole agency is addressing as a whole. I'm sorry I had to skip through this pretty quickly, but I know we're just quite short on time. So these are some, and Scott, I think you said folks are going to have access to the slides afterwards. So these are some resources that are available. There is actually quite at least some information out there about looking at the issue of secondary trauma in school settings. So I would encourage people to follow up and look at these links, and I will leave it at that.
Okay, thank you, Erika. Let me see if I can get to the last item. Yes, so before we leave, again, in the participants' chat, many questions were answered. There were some questions regarding access to the screening tool. If Adam, you want to put that answer in the chat before we hang up here. Also, there was another question about the differences between TST versus wraparound services. I think there are a number of differences. And again, I think as Erika had said in the previous slide, if you go to the NCTS network, you'll find some of those answers regarding trauma-aware schools. But we do want to thank all the presenters, and also thank Mariola Rosa from the NASD and Mary Dino, the Senior Program Coordinator for TST at NYU Child Study Center, for really getting our facilitators today and really putting this together. We want to make the announcement that the annual School Mental Health Conference this year will be held November 5th through the 7th, 2015 at the Sheraton New Orleans Hotel in New Orleans, Louisiana. The theme of the conference is Getting Jazzed About School Mental Health, celebrating 20 years of advancing school mental health. So please be on the lookout for those announcements at the IDA partnership. Again, I want to thank Sandy, and I want to thank everyone for coming on board this afternoon or this morning, depending on what time zone you're at. We appreciate it, and everyone have a great weekend.